Ladies and gentlemen, my today's presentation is Understanding New Therapeutic Strategy in Castration-Resistant Prostate Cancer. I'm from Binh Dan Hospital, Ho Chi Minh City, Vietnam. For introduction, according to New Shore, 20% of prostate cancer patients progress to castration resistance during 5 years of follow-up, with more than 80% having metastasis at the time of diagnosis. Despite recent advances in CRPC treatment, overall survival remains low. It is the critical stage of the disease that threatens the patient's life. The new terminology, castration-resistant prostate cancer. The prostate cancer group, working group 2, introduced the term castration-resistant to classify tumors that progress despite castrate level of testosterone, but remain potentially sensitive to further inhibition of the AR axis. Recent advancement in management prostate cancer includes more accurate androgen assay, new imaging technology, identification of genetic factors or mutational events, approval of several advanced new therapies. In this slide, we see the many clinical stages of prostate cancer, from the localized or locally advanced prostate cancer to biomedical recurrence, NMHSPC, and after that, the CRPC stage, including the NMC, non-metastatic CRPC, and then the metastatic CRPC, which will lead to the terminal stage of the disease with death of the patient. Prostate cancer is a continuum of different disease stages. Localized disease is a cancer that remains within the prostate. However, it may represent with regional spread or distant metastasis. ADT prevents tumor progression by reducing levels of circulating androgen. It can be achieved through surgical castration or medical castration. Ultimately, most prostate tumors will progress to CRPC within 2 to 3 years of initiation of ADT. In this picture, we see that in CRPC patient, the M-CRPC metastasis CRPC clinical stage has higher rates of annual progression and mortality relative to the localized non-castrate and non-metastatic stage. It has the highest annual progression rate, 74%, and the highest mortality rate of 56% in this final stage. Definition of castration-resistant prostate cancer. According to the guidelines, the NCCN guideline 2022, CRPC prostate cancer that progresses clinically, radiographically, or biochemically despite castrate level of serum testosterone under 50 nanogram per deciliter. Patients whose disease progresses to RPC during primary ADT should receive a laboratory assessment to assure a castrate level of testosterone. Finally, imaging tests may be indicated to monitor for distant metastasis. The definition of the EAU. In this definition, the CRPC is the castration serum testosterone under 50 nanogram per deciliter, plus biochemical progression, that is 3 consecutive rises in PSA 1 week apart, resulting into 50% increase of the nadir with the PSA more than 2, or radiological progression. That means the appearance of new lesions, either more than 2 new bone lesions on bone scan or a soft tissue lesion using the RECIST criteria. It should be noted that symptomatic progression alone is not sufficient to diagnose CRPC. The impact of improved androgen assay on definition and diagnosis of CRPC. The findings from the novel androgen assay with increased sensitivity. The standard assay determined that bilateral orchidectomy resulted in serum testosterone levels of 50. The recent improvement in laboratory assay enabled detection of much lower concentration and confirmed the castrate level of testosterone are under 20. A recent systematic review reported that emergence of CRPC was delayed by up to 6 years in patients with low nadir testosterone levels of 22 nanogram per deciliter. In 2014, the EU lowered its recommended targeted level for testosterone to under 20. The FDA guideline in 2019 stated that the percentage of patients achieving and maintaining testosterone under 20 should represent a secondary endpoint in clinical trials. For the implications for the definition of CRPC, you can see many CRPC definitions according to different guidelines, such as the EU, AUA, NCCN, ASCO, ESMO, etc. A new definition could recommend that castration resistance be confirmed with rising PSA or clinical radiologic progression only when testosterone is under 20 nanogram per deciliter. The pathophysiology of progression to CRPC. Prostate cancer develops as a population of relatively homogeneous hormone-sensitive cells. As the majority of cells are androgen sensitive, ADT leads to disease regression and a decline in the PSA. Progression to CRPC occurs when the tumor cell proliferation burgeons concomitantly with castrate level androgen and rising PSA. Androgen insensitive tumor cells that were originally present in small numbers arose through gene mutation, multiply in this environment until the overall neoplastic cell population shifts become predominantly hormone insensitive. When high proportion of androgen independent cells are present, there is loss of effectiveness of ADT, resulting in increased tumor growth and rise in PSA. This mechanism is also seen in many other cancers, such as colon, kidney, pancreas, and liver. In this picture, we see that in the pathophysiology of CRPC, there is still a continued importance of the AR and the hormonal signal. For example, the androgen production, adrenal glands, and prostate tumor, the AR overexpression, the AR splice variants, the AR mutants, all of these lead to the upregulation of the AR cofactors, leading to the tumor progression. That means the CRPC. The predictive factors for CRPC. We have known the prognostic factors such as the Gleason score, the high metastatic burden and the de novo presentation, and the time of metastatic occurrence and the volume of the disease. The hereditary genetic factors and mutation included activation or amplification of the ARs, gene mutation, pathogenic germline variants, circulating microRNAs, DNA sequencing analysis, and the Polaris cell cycle progression test, and finally the decipher. But unfortunately, these tools are not yet widely validated. In the predicting factors for the progression to CRPC, we see that the majority of the patients had molecular alterations. Approximately 90% of the mCRPC patients had clinically molecular alterations. And 23% of the mCRPC had DNA repair pathway aberrations. The DNA repair pathway aberrations play a role in the progression to CRPC, in which the HRR, homologous recombination repair, is a key mechanism. For the hormonal kinetic of testosterone and PSA, Men with non-metastatic prostate cancer receiving intermittent ADT that have a longer time to PSA rise during the first off-treatment interval were associated with lower risk of CRPC. And secondly, a low baseline testosterone under 11.5 is prognostic for the survival of mCRPC patients. For the novel prognostic approaches, we have the newer biomarkers such as the neutrophil to lymphocyte ratio, prognostic index model using 6 risk factors, plasma cell-free DNA AR amplifications, and post-scan index. There are advancements in CRPC therapies. Understanding of the biochemical pathway in prostate cancer and CRPC deepened. The treatment options have expanded beyond traditional ADT to include combination therapies that further eliminate AR signaling. It's imperative that patients continue ADT in combination with additional treatment, even when progression to CRPC, mCRPC has been confirmed. The main reason for continuing ADT is to prevent repopulation of the androgen-sensitive tumor cells that persist through amplification of the AR or development of the AR mutations. Highly adapted tumors may be also sensitive to androgen signaling. It's important to maintain low androgen level of testosterone under 20. The AR targeted agent, the ARTA, have clinically significant impact on the androgen axis when given concomitantly with ADT to achieve maximal inhibition of the AR activation. There are the recent phase 3 the trial that randomized men with non-metastatic CRPC to ADT with darolutamide, apalutamide, or enzalutamide, all of which shows the survival benefit of the combination therapy versus the standard ADT. Recent approval of ARTA for patients with mCRPC provide further evidence that earlier use of the androgen therapy inhibitors delay disease progression and improve survival. But it should be noted that up to 17% of patients undergoing treatment with abiraterone enzalutamide had neuroendocrine tumors. Thus, regardless, suppression of androgen pathway may induce neuroendocrine differentiation. Additional treatment of mCRPC include taxane-based agents, immunotherapy, and radium-223 dichloride. Questions remain regarding the interplay of resistant tumor biology and optimal sequencing for the CRPC. It should be noted that the CART trial suggests that sequential use of ARTA is effective than using chemotherapy. And this table shows the common CRPC treatment options. The drug classes include the taxane-based chemotherapy, immunotherapy, androgen cytochrome P17 inhibitor, radiopharmaceutical, and the anti-androgen. It should be noted that the enzalutamide, apalutamide, and darolutamide are approved for the non-metastatic CRPC. And this is a timeline for the emergence of new treatment options for the mCRPC, ranging from bitosantrone to docetaxel, cabazitaxel as chemo. For the immunotherapy, we had sipuleucel T, and for the ARTA, we have the abiraterone enzalutamide. In the docetaxel failure or the chemo naive, and the radium-223, and recently the approval of PARP inhibitors such as the olaparib. For the non-metastatic CRPC management, the EU guidelines said that 3 large RCT, prostate RMS, evaluate metastasis-free survival as primary endpoint in patients with NMCRPC treated with enzalutamide, apalutamide, or darolutamide, and there is a survival benefit when using the combination of the ADT with one of these agents. According to the EU guideline, the approved agents for the treatment of mCRPC in Europe are docetaxel, abiraterone, enzalutamide, cabazitaxel, olaparib, radium-223. The first-line treatment of mCRPC are abiraterone, enzalutamide, docetaxel, sipuleucel-T, ipatasertib. The second-line treatment for mCRPC and sequencing are cabazitaxel, abiraterone acetate after prior docetaxel, enzalutamide after docetaxel, and radium-223. And recently, the PARP inhibitors and the newer immunotherapy were approved for the mCRPC. The PARP inhibitor includes olaparib, which is approved by the FDA and the EMA for the germline or somatic HSS gene mutation mCRPC, or the BRCA1 and BRCA2 alterations. And the pembrolizumab is approved by the FDA for the microsatellite instability high, or the mismatch repair deficiency. The recap for the fundamental treatment of mCRPC, the study, we have many studies, for example, the Thach 327 for the introduction of docetaxel, the impact for sipuleucel-T, the QAA 301, QAA 302 for the approval of abiraterone for the mCRPC, pre or docetaxel, the PREVAIL or the AFFIRM study for the approval of ENZA for the mCRPC in pre and post docetaxel, and the TRAFFIC, the ALSIMCA and the PROFILE study for the approval of cabazitaxel, radium-223, and olaparib. And all of these shows a benefit, survival benefit, as shown in this picture. For the conclusion, the goal of therapy for advanced prostate cancer is to delay disease progression and prolong survival. ADT aims to achieve and maintain the lowest possible levels of testosterone. There have been many advances in the treatment of CRPC over the past decade, but much remains to be done as many patients are still dying at this stage of the disease. Many therapies have been approved: chemo, ARTA, PARP inhibitors, immunotherapy. The cost and side effects needs to be taken into account. Further understanding of the biology of progression of prostate cancer, identification of therapeutic resistance, and development of novel therapies for CRPC are promises for improving the survival. Thank you very much.